I'm going to be talking to us today about how implementation research is applied to leverage universal health coverage. So I thought about it and I thought about the title for the session, and I felt it was more appropriate to speak to the universal health coverage since that's the focus of this session. So while we wait for the slides to load up, I just want to say that implementation research is useful for supporting delivery of evidence-based intervention, and at the same time, it's also useful for strengthening the system in which the intervention is being delivered. So there are often two schools of thoughts. So some people see implementation research from the perspective of supporting delivery of interventions, such as intervention that addresses specific diseases, while others also see implementation research as being very useful for addressing critical bottlenecks within the system and the context in which the intervention is being delivered. And TDL, traditionally has looked at it from the intervention perspective, but increasingly, I believe the research is beginning to see that in order to facilitate the impact of interventions, we need to address the system. So my discussion today is really going to focus on the health system and less on the diseases. And to do this, I'm going to be focusing on a case example on how implementation research has been used to strengthen health system in Afghanistan, looking at how pay for performance was used to address critical bottlenecks in services delivery to facilitate universal health coverage in Afghanistan context. Universal health coverage, simply put, is really the goal of having heavy people have access to health services of sufficient quality in a way that it doesn't adversely affect their finances, that is, in a way that it doesn't cause any financial hardship. And there are different aspects of the system that contribute to universal health coverage, including the health financing in terms of where the money to finance the health services is going to come from, and also how the services are being purchased, and also how the services is being delivered. And obviously the health workforce that provide the services and the information system and data that is used for research. So all of these are all critical components for providing universal health coverage. And there are different strategies that could be addressed to any one of these different components. So today, I'm going to just be focusing on one of those strategies, which is pay for performance, that was used in Afghanistan to address critical bottlenecks with regards to services delivery and strategic purchasing of health services. So in Afghanistan, the pay for performance intervention was really this idea of giving incentives, that is to give money to healthcare workers based on the additional number of services or number of people that they are able to attract into their facility, and also based on certain quality indicators. So the idea is that the government in Afghanistan wanted to rapidly expand coverage of critical services to its population, and they recognized that they could do this. One of the ways of doing this strategically is by giving monetary incentives to health workers to encourage them to invite more people into their facilities and also to improve their services. So indeed, money was targeting volume of service and quality of service. And this was done on a pretty large scale, covering about 11 provinces out of 34 provinces in Afghanistan. And it was such that money payment was made towards specific maternal and child health services, including antenatal care services, postnatal care services, and other kinds of services that targeted child health care. And the expectation is that once you give money to these health workers, that they will improve their quality of service, and then they will invite more people. That will invite more people into their facilities. So often where we start from is to ask the question for any program is whether it worked or not. And back in 2016, I was working in Afghanistan, And the question the World Bank and other people were trying to ask was, is this pay-for-performance intervention working in expanding coverage? Is it working in helping to improve quality? So we did this very elaborate cluster randomized trial, very elegantly designed, and we're looking at health outcome at the population level, also looking at outcome at the health facility level. And we did the experiment, and at the end of 2 years, we realized that when we compare facilities and population that were exposed to the pay for performance to the population and the facility that were not exposed to pay for performance, there was really no difference with regards to the indicators of coverage and quality that we were looking for. So for instance, prevalence of contraceptive use didn't change. Neither did we see any increase in the number of antenatal care services or people that were coming for antenatal care service comparing those two harms. And the same was true even for indicators of quality and indicators of performance of the healthcare facilities, looking at the infrastructure of the facilities, looking at the availability of pharmaceuticals and other kinds of equipment for delivering services, even looking at the satisfaction of health workers and so on and so forth. So, and the question was why? The question was why. And this is often where a lot of research focuses on. Most efficacy and effectiveness research often focuses on finding whether something works or not. But to illustrate the utility of the implementation research for addressing questions around universal health coverage, we said, okay, we know that this does not work. And implementation research would ask the question of why does it not work? Or how did it not work? And that was what we decided to do. So, okay, yes, we know that this does not work. So the question is, why did it not work? And how did it not work? Which are often the kind of questions that we try to address using implementation research. So what we did was to think about all of the complexities that are involved in providing healthcare services in Afghanistan, looking specifically at one health facility, and to look at the interactions between the different processes that are involved in providing incentives and how those incentives lead to an improvement in volume and quality of service. So we did what we call a system dynamic model, and what we tried to do was to imagine that it's not as simple to just give money to healthcare workers. It's okay, I'm going to give you money, and then I expect you to improve your services, and then I expect you to get people to come to the facilities to use the service. There are a lot of complex interactions that are taking place. And some of these you cannot rightfully model using your traditional research design, including the cluster randomized trial that we've done. For instance, we know that PDF, which is the performance-based for financing, was actually opening gates of motivation. That is to say, it was motivating healthcare workers. The anticipation that it will motivate healthcare workers to improve their quality of service, and when they improve their quality of service, the quality of service will in turn attract people into the facility, and then as you have more people coming into the facility, there's a tendency for the quality to be compromised because there's a capacity beyond which the facilities cannot provide services at a certain quality. And all of those complexities we had to model to just imagine what was really going on in the facility. And we also know that there were opportunities for cheating, which we call gaming. People can lie to say, okay, I provided these services, or I provided these services at a certain quality in order to attract the incentives. And then we were able to use a mathematical model that allows the flexibility to model all of these complexities and feedback and the interactions. And then, next slide, please. Okay, and then we went on to say, okay, even though the simplicity of the design was that you give money to NGOs, and the NGOs would distribute the money among the health workers based on the performance of the health workers. But what we realized was that there were three major implementation scenarios on how money is being distributed within a facility. So there was a scenario in which in every facility, money is given equally. That is to say, the additional bonus or the incentives is divided equally among all health workers within that facility. And then there was another scenario where in some health facility, they were giving money proportionate to the salary. That is to say that whoever earns the more in the facility gets the most out of the incentives. And then there was another scenario in which they were actually distributing the money based on the contribution of the individual to the services that triggered the payment. For instance, if the money was being paid for skilled birth attendance, they would give most of the money to the midwife that delivered the baby. Or if the money was being given for antenatal care services, the money would be given to the nurses that actually provided the antenatal care services. And then we realized that in putting all of this together, that all of these implementation scenarios actually have a different impact and results. Next slide, please. Next slide. So what you want to see, what you want to look for is anything above 0 in the graph, it's good. And anything below 0 is bad. So you will see that when you model the interactions within the system, you will see basically that's the baseline. The quality and volume of services almost often falls on the line of 0. That is to say, things are neither improving nor getting worse. And then when you introduce pay for performance, there's a tendency for both the quality and volume of services to the line to go above 0. That is to say, both volume and quality of services are quite improving. When you consider motivation, that the pay for performance was actually motivating the health workers, the rate at which facilities were getting to the higher level of quality and volume was much faster. They were getting there at a much faster time than when you didn't consider motivation. And then when you consider gaming and cheating, what happened was that the motivation of the health workers, the volume and the quality of services of the health worker was actually falling below 0 line. This is to say it was falling below when you did not do any intervention. That is to say if you don't address things like cheating within the implementation of pay for performance, you will find a scenario where things get worse than if you do not do any intervention at all. Next slide, please. And then when you look at the different implementation scenarios to distributing the incentives among the health workers, you realize that if you allocate the money equally amongst health workers, it really did not change from 0. Because what was happening was that there were people within the health work team that were doing most of the work. And those people weren't feeling as if their input were being appreciated, because despite the work that they've put in to get the payment into the facility, they are not getting any additional incentive on top of that. And then when you do proportionate to salary, in fact, that was demotivating, particularly to some of these mid-level health workers that were the ones that were actually providing the services, because they were getting less compared to some of the leaders in the health facility. And then when you pay the money proportionate to what contribution you made to the services, you will see that the line all falls above 1. So the critical point here is really to show you how implementation research can actually allow us to unpack why an evidence-based intervention like a pay-for-performance scheme might not work or might work, and what are some of the reasons why it's not providing or producing the effect and the result that you hope to see. Next slide. So we're able to pull all of this together, and this was really very helpful for the government of Afghanistan, even to retweak the pay-for-performance scheme, to retweak the way purchasing was done, to retweak the way facilities were distributing incentives within their facilities among the health workers, and to improve even the performance of the health system, looking at the quality and the volume of service. Because when we looked at the subset of facilities where the money was being paid proportionate to services, the quality improved significantly, and also the volume of service also improved significantly. And this was again spread to other facilities within the Afghanistan health system. So this is just one illustration, it's just one case study to show you how implementation research can be useful for unpacking why complex interventions that are often used to address health system, including goals of universal health coverage, can work better. And this has been done in other ways in other countries. For instance, there are studies in Indonesia that has looked at how using implementation research to address critical bottlenecks to national insurance scheme. There are studies that have been done in Nigeria looking at pay for performance and health worker satisfaction. And beauty is that implementation research could be addressed to either at the small scale to addressing operational research within facility, within particular setting, or at a very large scale to looking at a large-scale impact of evidence-based intervention across a very large population. Next slide. So, indeed, I would say that implementation research has promise for actually facilitating large-scale impact of health interventions in low and middle-income countries. And as we can see from the example in Afghanistan, that it has relevance for helping us to study implementation bottlenecks, challenges around strategies for achieving universal health coverage, and for generating real-time corrective measures. Thank you.